Have you ever stopped to think about the ultimate medical paradox? I mean, the very medicines that we completely rely on to heal us, to wipe out dangerous pathogens, can actually turn around and roll out the red carpet for a deadly, life-threatening infection. It sounds totally impossible, right? But it actually happens every single day in hospitals all around the world.
Welcome to This Explainer. Today we are diving into what is essentially a microscopic medical thriller, and it's unfolding right inside the human body. We're going to break down the clinical journey of a notorious bacteria known as Clostridioides difficile, or as it's way more commonly called in the hospital halls, C. diff.
So, here is our roadmap for today. We'll cover 1. The antibiotic paradox. 2. How toxins break the gut. 3. Severe and deadly complications. 4. Diagnosing the infection. And finally, 5. Defeating the bacteria.
All right, let's jump right into Section 1, the antibiotic paradox.
Are villains sheer resilience? It's honestly just astounding. C. diff is a gram-positive anaerobic bacterium, meaning it actually thrives where oxygen is scarce. But its real superpower is its ability to form spores. And these spores are gnarly. They are so incredibly tough that they can easily pass right through the highly acidic environment of your stomach and just confidently make their way down into the colon. Now, normally, they just sit there, kept perfectly in check and suppressed by your healthy, normal gastrointestinal flora, the good bacteria.
But here's where that paradox strikes. When a patient takes antibiotics, especially those in a high-risk group we can remember as the 3 Cs, so that's clindamycin, cephalosporins, and ciprofloxacin, or really the broader fluoroquinolone class, a massive shift happens in the body. These antibiotics act like a bomb going off in the gut. They completely wipe out that good, protective, normal flora. And without the healthy flora there to suppress them, those tough C. diff spores suddenly wake up, germinate, overgrow, and start taking over the colon. Recent hospitalization is another massive risk factor here, mainly because those tough spores can linger on surfaces and easily transmit to vulnerable patients.
Moving right along to Section 2, how toxins break the gut. So this brilliantly illustrates exactly how the bacteria actually inflicts damage. The bacteria itself doesn't eat the tissue. Instead, it releases these nasty toxins, specifically toxin A and toxin B, with toxin B being the most destructive of the two. These toxins enter the colonocytes, which are the cells lining the colon, and they act on an enzyme called Rho-GTPase by adding a sugar molecule to it. This process is called glycosylation, and it completely shuts down the enzyme. Why does that matter? Well, because without Rho-GTPase, the cell can't build actin polymers. That's the vital structural scaffolding that holds cells tightly together. As a result, the tight junctions between the cells just break apart. The barrier fails, creating this massive paracellular leak. It's literally like a dam bursting inside the gut wall. Now, the big takeaway here is that this microscopic cellular leak translates directly to the hallmark clinical symptom we see on the ward: severe, massive, watery diarrhea. Clinically, that's defined as 3 or more liquid stools per day. Because that tight junction seal is completely broken, water, sodium, and chloride leak straight out of the bloodstream and pour into the intestinal lumen. And guys, it's not just a nuisance, it's a critical danger. Losing this much fluid can cause the patient's blood volume to absolutely plummet, leading to low blood pressure, a compensatory rapid heart rate, and even acute kidney injury simply because the organs aren't getting perfused with enough blood.
Which brings us to Section 3, severe and deadly complications.
First, let's look at standard colitis. As the gut cells die from the toxins, they release alarm signals, like interleukin-8, which calls in a massive swarm of white blood cells, especially neutrophils. Now, these neutrophils mean well, but they are kind of like chaotic toddlers. They release reactive oxygen species to kill the bacteria, but that causes intense collateral damage to the bowel wall, making it incredibly inflamed and painful. Then, compare that to what happens when this escalates into pseudomembranous colitis. All those dead cells, inflammatory fluid, neutrophils, fibrin, and mucin pile up, forming this thick, yellow, plaque-like membrane directly over the inflamed colon. It's a very distinct hallmark visual cue for doctors.
But wait, the inflammation can cause something even more terrifying: toxic megacolon. When severe inflammation triggers the production of nitric oxide, it acts on the smooth muscle of the colon and literally paralyzes it. The colon just loses its tone. It completely stops contracting. We call this an ileus, and as gas and stool back up, the colon starts stretching dangerously, eventually dilating past the critical threshold of 6 centimeters. Now, here's a really scary clinical pearl for you. If a patient with explosive C. diff diarrhea suddenly stops having bowel movements and their abdomen becomes massively distended, it might not mean they're getting better. It could actually mean their colon has paralyzed and dilated into a toxic megacolon.
So let's trace how this builds into the absolute worst-case scenario. As that paralyzed colon stretches like an overfilled balloon, the tension on the bowel walls skyrockets. This immense pressure actually pinches off the blood vessels feeding the colon, leading to ischemia or lack of oxygen, and eventually the tissue dies and turns necrotic. And as we know, a necrotic wall is a weak wall. It perforates. Suddenly, gut bacteria flood into the sterile abdominal cavity, causing peritonitis. From there, the bacteria cross right into the bloodstream. The body's immune system panics, releasing a massive storm of cytokines that cause all your blood vessels to dilate and leak at once. Blood pressure crashes, organs fail. This is full-blown septic shock.
Okay, let's talk about how we track it down in Section 4, Diagnosing the Infection.
Clinicians rely on a super-specific algorithm using liquid stool samples. And by the way, you absolutely cannot run this test on solid stool. First up, we test for the GDH antigen. If that's positive, it simply means C. diff bacteria is physically present in the colon. But because a small amount of C. diff can actually be normal for some people, we need to know if it's the dangerous kind. That is where the toxin EIA comes in. We run it to look for the active toxins themselves. If both of those are positive, you have an active C. diff infection. But what if the GDH is positive, but the toxin EIA is negative? Well, then we use a PCR test as a tiebreaker. The PCR amplifies the bacteria's DNA to see if it carries the specific genes capable of producing those deadly toxins.
Once it's diagnosed, doctors urgently need to grade the severity of the infection so they know exactly how hard to fight back. The absolute critical threshold to remember here is 15,000. If the patient's white blood cell count skyrockets over 15,000 and their creatinine levels bump up past 1.5, which indicates kidney stress from dehydration, the patient has officially crossed from a non-severe to a severe infection. And if they have a high lactate level or their blood pressure drops, they are in the fulminant or extreme category.
Finally, Section 5, Defeating the Bacteria.
So the treatment here must be highly targeted. For non-severe and severe cases, we use oral medications, either fidaxomicin, which is actually preferred, or vancomycin. Now you might wonder why oral? Because we want the antibiotic to stay directly inside the colon to fight the C. diff right where it lives, rather than getting absorbed into the bloodstream. But if a patient is in a fulminant state, meaning they have that toxic megacolon or an ileus, their gut isn't moving at all. Those oral pills won't even reach the infection. That's when doctors must add IV metronidazole to attack from the bloodstream, and if the bowel's necrotic or perforated, surgeons have to step in immediately to remove the diseased colon. Oh, and a totally, absolutely crucial note here. Never give these patients antidiarrheals. Stopping the diarrhea just traps those destructive toxins right inside the colon.
Now, C. diff is a notoriously stubborn opponent. It loves to form spores and just come right back. If a patient gets a first recurrence, doctors will use a prolonged, slow taper of vancomycin or a course of fidaxomicin. For high-risk patients, they might even add this incredible antibody called bezlotoxumab, which literally binds to and neutralizes toxin B in the gut. But what if the infection comes back a second, third, or fourth time? Well, then we have to reset the battlefield entirely using a fecal microbiota transplant or FMT. Yes, literally a highly purified stool transplant. This involves taking stool from a healthy donor and delivering it into the patient's colon to physically replenish that good bacteria, restoring the peace and suppressing the C. diff for good.
And well, that brings us to a pretty profound realization. We spent so much time today exploring the destructive power of this microscopic villain and the high-tech drugs we use to fight it. But perhaps the biggest takeaway from this entire medical thriller is right here. In the unending war against infections, is our own natural gut flora actually our greatest ally? It really makes you appreciate the delicate, invisible balance inside your own microbiome. Thank you so much for joining me on this explainer. Keep wondering, keep learning, and I will catch you next time.